So I'm Nancy Smit, and I am a partner in Rosen Saperstein Friedlander, formerly founder and CEO of SHR Associates in Annapolis, Maryland. So my career, I started out as a physical therapist and landed in Washington, D.C. My sister was down here, and so I was hired by Georgetown University and worked for there at Georgetown several years, and then ultimately became the director of rehab medicine at Washington Hospital Center. Found that as much as I enjoyed healthcare and working with patients, I also enjoyed managing, and I enjoyed mentoring people. And so I found out about Loyola's executive MBA program, and at that time there had been a physician who convinced Loyola that they should do an executive healthcare program with a healthcare slant. So they called it their RX MBA. So in 1978 I started with Loyola's executive program and met Ed Science, who ultimately we worked together in school, and convinced me at the end of the program that we had worked so well together that we should form a company. We spent about 6 months thinking about what we should do, and he said to me, physicians need help with their practices. They're, very, very smart people, but they're not great in business. And so that's what we did. We actually formed the company in January of '81, and because of a relationship with Hopkins and the doctors at City Hospital, we started working with academic practice plans, actually looking at doctors who were on the city or county payroll at a public hospital, as the doctors at City Hospital were, and they ended up being able to separately incorporate their practice into a 501c3 corporation. So that model got published, and they needed someone to go out and actually do that work. So Ed and I had an opportunity to work with University of Michigan and their practice plan, and out at University of Chicago, and so that got us into the guts of, deep into the trenches of physician practices, forming them from scratch, and then we had an opportunity to manage some of those physicians for about 8 years or so. We were on planes, he and I, and then we hired some additional staff, but had employees and physicians all over Michigan and Illinois, and then started transitioning a little bit more into best of breed, kind of single specialty, independent practices back a little closer to home. So I'd gotten married in the meantime. So, and that's what we started doing, is really working with high quality physician groups, as I say, helping them bring the business side of the practice up to the quality of the clinical care. So we focus on operations, we focus on efficiency, we focus on really enhancing their profitability and hopefully their responsiveness to patients. I think some of the most interesting projects we had, one was separately incorporating all 50 full-time and 250 part-time physicians at the teaching hospital for the University of Michigan in Wayne County General Hospital. All of those doctors were on the county payroll, and by doing the feasibility, we determined that they could separately incorporate themselves, have a flow of funds from the university, have a flow of funds for the indigent care they did from the county, and start to do their own billing. So then we ended up getting the management for that new physician corporation and did that model both in Detroit and in Chicago. As a result of that, we met several physicians that were working at University of Michigan that then transitioned out into private practice. So one of the first kind of centers of excellence as an independent practice we worked with was Joel Saper's Michigan Head Pain and Neurological Institute. So Dr. Saper had decided that the world wasn't taking headaches seriously. He was a neurologist at the university, so he formed his own company in Ann Arbor and then wanted to promote and grow the business. So we helped him create his Center of Excellence. He gets now patients from all over the world with really severe head pain. And then he introduced us to a friend of his who is an otologist and neurotologist, which is for the ear, specialists in the ear, and particularly tumors of the ear, acoustic tumors. Malcolm Graham wanted to do something similar for ear tumors, so we helped him create the Michigan Ear Institute. And so again, kind of just building it from scratch, even creating a fellowship program for advanced training for residents that then wanted to go further, ENT residents that wanted to do their fellowship. So both just really doing every aspect of the business side with high quality physicians and helping them really build a center of excellence. So I think those were some of the most exciting initial projects that we did. And then as we started to come closer to home and a little more current with the ACA and some of the changes in healthcare, in the last 5 to 10 years, we've become very involved, both we're remaining in independent practice, but also in public and community health. One of the, I think, most gratifying projects we've had over the last 5 years or so is we were given the opportunity through the Maryland Department of Health and Mental Hygiene, DHMH, and CDC to visit all 24 health departments in the state of Maryland to assess their readiness for billing, because they're being now tasked with creating a billing infrastructure because more of their patients are now getting insured, where previously the state just funded all of that activity, or the counties that they were in, or a combination of both. So we now have become very involved with all of the health departments in the state of Maryland, also working with the Primary Care Coalition, which is a nonprofit arm of Montgomery County, over a lot of formerly free clinics in Montgomery County that also now are trying to build the infrastructure for billing patients who do have insurance. So the relationship with Rosen, Saperstein, and Friedlander came about. Actually, Howard Rosen contacted me about 5 years ago. Howard had got our name from MedChi, from the work we were doing, some consulting work with the Medical Society of Maryland. And RSNF had decided that they wanted to get more involved in the healthcare space and felt that they would rather find a company or a firm already in the healthcare space and rather than grow it organically. So he contacted me. I had not thought about merging, but I also really didn't have a succession plan. At that point, my partner, Ed Science, had passed away. And I had many employees who've been with me 20, in some cases 30 years. And we've had a wonderful run together, but everybody was starting to age up a bit. And so Howard approached me, and we met on an afternoon, and he talked about the vision of RSNF for having a healthcare arm. And we actually decided to do a joint venture. So for about 2.5 years, we formed another company, a small company that we both, as a joint venture, and that took us into Florida. We actually agreed that in addition to the work that our firm, SHR, was already doing heavily in the Mid-Atlantic, we had some clients, long-term clients, and still do, in New Hampshire and Rochester, New York, so up and down the East Coast. But I knew that I had been spending some time in Florida. I have a 94-year-old dad who lives in Florida, and my son was getting ready to go to the doctorate in physical therapy at University of Miami, so I was highly motivated to go to South Florida. And honestly, Maryland is a very difficult state with the HSCRC. Physician reimbursement actually is one of the lowest in the country for physicians. And with more physicians moving into employed relationships, it was my understanding that physicians in Florida were still a little more fiercely independent, that they were looking for support, and because of all the Medicare, our firm also does a lot of compliance work from a billing standpoint, working with lawyers and physicians on enhancing and making sure that the physician billing is done accurately, properly, completely from a compliance standpoint. So, and with Medicare stepping up their compliance efforts, really all the payers felt that there would be good opportunities for us in Florida. So we started to meet members of the Medical Society and some lawyers down there, and As a result of that, for the last year, I've been on a plane just about every week to Florida as the executive director of a 17-doctor gastroenterology group. So we took over management of that group. So it's been a great relationship. And then actually just January of 2016, I formally merged SHR into RSNF, and so I now run the healthcare division, and I'm one of the 4 partners. And it's been a wonderful relationship. And one of the reasons I did it was because I saw the handwriting on the wall with the changes in healthcare. In my firm, we were about 10, mostly practice administrators. We had business backgrounds, some of us have clinical backgrounds. But with all of the changes in healthcare, I really felt that it would be very helpful to have 40 accountants behind us. When you start looking at the economics of healthcare practice and the bundled payments and pay for performance, that being able to really bring both sides together, the heavy financial side and strategic, because we both our firms are very involved in advising physicians and businesses in a strategic way. And it's been really a great partnership and worked very well for our clients. So just speaking about the difference between the operations and some of the strategic needs of hospital-based physicians versus independent practice versus community-based, they're very different, actually. The hospital-based physicians often have a lot of the business infrastructure from the hospital side. So they have finance people and they have their compliance team. So often when we've worked with the hospital-based physician groups and the hospitals, it's really more on just maximizing physician billing. Sometimes there's a disconnect between the clinical side and the business side. So just making sure from both a compliance and a reimbursement maximization standpoint that the hospital-based physicians, are operating efficiently, and that their departments, we do go in and look at general operations. On the independent side, it's really all aspects. Sometimes they're looking for growth opportunities, and we get into the marketing side. Sometimes it's really from a compliance standpoint. Let's just make sure we're doing everything we need to do. From a regulatory standpoint, we just don't want to get in trouble. We want to be able to continue, and really just making sure for the independent practices, it's a challenge because they need to be embracing technology. It's expensive. So when we can find opportunities for them to make sure that they are coding appropriately, documenting appropriately to maximize what they can for their reimbursement, but also embracing technology often means that they don't have to hire that next person, that they can streamline, there isn't as much paper flow. And we often find in the smaller practices, there's just a lot of duplication of effort. So just coming in independently, building a stronger business infrastructure, and then their management can run on that stronger base. The community and the public health sector is an entirely different animal. And there's just such limited resources. One, it's probably the most gratifying work we do because they are so appreciative, and they just don't have, in many cases, the skill sets to even build the business infrastructure they need. So fortunately, there is a fair amount of independent funding. We're working with a group right now called Upstream USA, and they have private investors, and their goal is to help decrease teen pregnancy. So they're working with women's groups, not just public, but community and even independent groups across the country. And they realize that in order to accomplish their goal, they need the clinics to be viable, And so we're able to partner with them and go in and really do business infrastructure strengthening and streamlining, so that they can accomplish their goals, but they're funding a lot of our work. We have a really nice relationship with NIFRA, the National Family Planning and Reproductive Health Association. Again, a national organization that umbrellas over Planned Parenthood, women's groups of all types, do quite a bit of speaking for them, and also some of the internal operations and billing support. So it's just been a wonderful relationship, and can only imagine how much it's changed since 1981. So we've had to change as computerization has come in, as EMRs have come to the fold, as the regulations have changed. So it's a really exciting space to be in, and I just can't imagine doing anything else.